The Global Surgery Lab presents the 2-incision, 4-compartment fasciotomy of the lower limb. The goals of this video are to identify indications for a lower limb fasciotomy, summarize key anatomy of the lower leg, and to demonstrate a 2-incision, 4-compartment fasciotomy of the lower limb using the anterolateral and posteromedial approaches. A fasciotomy should be done when there is a clinical suspicion of compartment syndrome. In compartment syndrome, the pressure in one or more of the leg compartments disrupts circulation, leading to ischemia, permanent functional impairment, and possible amputation and death. Patients reporting pain out of proportion when the limb is passively stretched and tense compartments are clinically suspicious. A 4-compartment fasciotomy should be performed before the pathognomonic 5 Ps, pain, pallor, paresthesia, paralysis, and pulselessness, develop. To reduce pressure in the leg compartments, 2 incisions are made. The anterior and lateral compartments of the leg are opened laterally, while the superficial and deep compartments are opened medially. The steps to performing the anterior lateral incision of this lower limb fasciotomy include landmarking, elevating a skin flap, locating and dividing the intermuscular septum, and opening the anterior and lateral compartments. You will need a knife and curved scissors. Skin retractors may also be helpful. As with all procedures, remember to follow all necessary surgical safety protocols and best practices. To landmark, find the lateral malleolus and head of the fibula. Draw a line between the two. Then, draw a punctuated line 1 to 2 centimeters anterior to the line of the fibula. The punctuated line is the incision landmark. Next, create the skin flap. Make 1 long incision through the punctuated line. A common mistake is to make the incision too posterior, missing the anterior compartment entirely, so make sure your incision is 1 finger anterior to the line of the fibula. The incision should be 12 to 20 centimeters in length, extending from 3 fingers distal to the head of the fibula to 3 fingers proximal to the lateral malleolus. Once your incision has been made, mobilize the skin to expose the fascia. Next, locate the intramuscular septum between the anterior and lateral compartments using the H technique. Make a perpendicular incision through the horizontal plane through the exposed fascia to make the crosspiece of the letter H. This incision should be a few centimeters long and expose the intramuscular septum. Finally, open the anterior and lateral compartments by sliding partially opened scissors through the length of your incision anterior and posterior to the intramuscular septum. These cuts will form the legs of the letter H. Ensure the tips of your scissors point up and away from the septum, and that the cuts are 1 to 2 centimeters away from the septum to avoid damaging the fibular nerve. Make sure to open the compartments along the full length of your skin incision to prevent the fascia from acting as a constrictor band. After the procedure is complete, do not close the wounds primarily. Leave them open for a minimum of 48 hours. Cover with sterile wet to dry dressings that are changed regularly, and consider a shoelace closure. The posteromedial incision of this lower limb fasciotomy can be broken into several steps including landmarking, creation of the skin flap, opening the superficial compartment, and opening the deep compartment. You will need a knife, curved scissors, and skin retractors. As with all procedures, remember to follow necessary surgical safety protocols and best practices. To landmark, find the medial malleolus, the medial condyle, and crest of the tibia. From the crest of the tibia at mid-shin, palpate posteriorly to identify the posterior border of the tibia. Remember that the tibia is triangular in cross-section. Your incision should be made 1 thumb posterior to the posterior aspect of the tibia in line with the medial malleolus and medial condyle. To create the skin flap, make 1 long incision through the skin parallel and 1 thumb posterior to the posterior aspect of the tibia using your knife. The incision should be 12 to 20 centimeters in length, extending from 3 fingers distal to the medial condyle of the tibia to 3 fingers proximal to the medial malleolus. Be careful not to damage the greater saphenous vein or nerve, and make sure you ligate any perforated branches of the saphenous vein, as these can be very superficial and bleed profusely. In this video, our skin incision was too short. Make sure to cut through the full length of your punctuated line. Mobilize the skin to reveal the underlying fascia. To open the superficial compartment, cut through the fascia 1 thumb posterior to the posterior border of the tibia using partially opened scissors. Open the fascia from just distal to the medial tibiocondyle to just proximal to the medial malleolus so that you can clearly identify the soleus muscle, a key step towards locating the deep compartment. To access the deep compartment, mobilize the fibers of the soleus muscle to separate these muscle fibers from the posterior aspect of the tibia. Separating the soleus from the posterior aspect of the tibia will reveal the fascia covering the deep compartment. Cut through the fascia into the deep compartment by sliding your partially open scissors along the fascia you've uncovered over the length of your skin incision. Note that the deep compartment can sometimes be confused for the pocket between the soleus and gastrocnemius muscle. Identification and visualization of the posterior tibial neurovascular bundle will confirm entry into the deep leg compartment. Make sure all leg compartments are open along the full length of your long skin incision to prevent the skin or fascia from acting as a constrictor band. After the procedure is complete, do not close the wounds primarily. Leave them open for a minimum of 48 hours. Cover with sterile wet to dry dressings that are changed regularly and consider a shoelace closure. In conclusion, a 2-incision, 4-compartment lower limb fasciotomy is used to treat compartment syndrome and prevent pain, function loss, and death.